Welcome, everyone. So we are very fortunate today to have 4 panel members to discuss together preventative healthcare for people experiencing severe and persistent mental illness. So I am very honored to introduce our honored panel members. I will start with, we are very grateful today to have an individual with lived experience along with their partner who's been their caregiver. So it's my pleasure to introduce, and I'm not sure if you're able to see on the screen, but the panelists, yes, the panelists are welcome to turn on their camera. So I'm very happy to introduce Mr. Larry Gower, who is a native Torontonian. He's a construction carpenter by trade. And Larry treasures and is so proud of his 2 beautiful children, Jacob and Emma, and his soon-to-be stepdaughter, Samantha. And he is also so appreciative for the support and partnership of his fiancée, Karyn. And last year, Larry underwent treatment for stage 3 colorectal cancer. And he's extremely grateful to his fiancée, Karyn, and to all the staff at Princess Margaret Hospital, as he reports that he is now in remission and loving life. And I will also introduce his partner, Karyn Hawco, who was also born and raised in Toronto and a mother of 1. She's trained in both property management and human resources management and has worked in these fields for 20 years. In 2017, she made a career change and became a certified personal support worker, and now is currently starting the social services program through Humber College coming up in January. She's a fiancée to Mr. Larry Gower, and she has been his primary caregiver since his diagnosis in April 2022. So we will very excited to hear a little bit more insights from Larry and Karyn. And we will also be joined in our panel by Dr. Gary Bloch. There he is. He is a family physician with St. Michael's Hospital and Inner City Health Associates, and he's an associate professor at the University of Toronto. His clinical program, innovation, education, research, policy, and advocacy interests focus on the intersection between primary care, health equity, and social determinants of health. He's the co-founder of the Physician Homeless Services Group, Inner City Health Associates, and the advocacy group Health Providers Against Poverty. He's developed numerous innovative clinical programs for primary care teams and educational curricula for healthcare trainees, and he served on an Ontario government task force targeting income security. So welcome, Dr. Bloch. And last but definitely not least, Dr. Daniel Rosenbaum, who is an attending psychiatrist at the University Health Network, as well as the Inner City Health Associates in Toronto. Dr. Rosenbaum is a clinical lecturer at the Department of Psychiatry, at the University of Toronto. And Daniel works on the Impact Assertive Community Treatment Team at UHN, as well as the Palliative Education and Care for the Homeless, PEACH team, throughout ICHA. He is also co-founder and faculty member at the UHN Psychedelic Psychotherapy Research Group, where he is a co-principal investigator with the psilocybin-assisted existential attachment and relational Pearl therapy research program. Pearl is a novel psychedelic-assisted psychotherapy for patients with advanced disease and their caregivers. And Daniel is also interested in the mental health impacts of climate crisis, including specifically the impacts on those with severe and persistent mental illness. So we have a wonderful panel here. Welcome to all of you. And if it's okay, we'll proceed with some of our first questions for each of you. And I think it will be a really rich discussion to hear different perspectives from those with lived experience, a caregiver, primary care, psychiatry, and how we can bring those perspectives together to create some meaningful changes. So without further ado, my first question is actually for our participants with lived experience, Larry and Karyn. Interested to hear a little bit about your experience being diagnosed and receiving treatment for cancer and being a caregiver to Larry during these experiences, and how that intersection of, a history of mental health care and interactions with the healthcare system, and how that changed your trajectory and where you went from there.
Yeah, well, I mean, when first diagnosed, I was just in shock. Like 'cause you never think it could happen to you, you know? Anyways, yeah, my first colonoscopy, my fiance had suggested I go early. I didn't really want to and this and that, but I went, and the first time I hadn't done the directions properly and didn't work, but I had to go back. But anyway, I did go back. I didn't want to. And when I went back, I was under sedation, and when I came around, one hand I was holding Karyn's hand, and one hand I was holding the doctor's hand. And sir, I regret to inform you, you have cancer. And I didn't know. I didn't know what to think or do. I went into a rage. I walked out with the gown still half open and still connected to the blood pressure monitor, and I suffer from alcoholism, so I was gonna go drink. I was going to go. I punched in my phone the for YouTube to, or not YouTube, sorry, Uber to take me to the liquor store, and my fiance and caregiver convinced me not to go. And from the days that followed, I just didn't know what to think. I was in shock. And it was hard. So getting back to how I was treated at the hospital, the staff were incredible. I mean, I don't know how they do their jobs every day. I don't. I couldn't do it. You know, I mean, I'm a success story. You have to face death every day, and thank God, I'm not one of those people. But the staff to smile and continue and to do their job and not try not to take it home with them. It's incredible. And Ulysses' help has been phenomenal. I mean, I not only got through it all, I learned about myself a lot too. And I learned that I'm stronger than I think, and all the support that I got, it was great. I was treated by one of the best surgeons in the country. You know what I mean? Like this disease doesn't discriminate. Whether you have money or what color you are. And just I owe everything to Mrs. Margaret and the staff and to my fiance, because I'm here now. I'm getting healthier every day, getting stronger every day. And I'm a walking miracle. So the challenges I faced were hard, eating was impossible sometimes. And I'm on assistance, I'm on an ODSP, and I'm not making a lot of money off of ODSP. It's hard to eat sometimes. And it's hard to recover when you don't have the money to buy food. But we got through, with help from food banks and family. But it's not easy when you don't have money. It's really hard. It's hard on our relationship. Karyn was close to burnout several times. And it was a strain on our relationship. We're getting married next year. Thanks, thank God that we are. I'm still going to be here. Christmas is coming. I'm so excited. It's going to be the best Christmas ever. So yeah, I've had the best treatment possible at Christmas market. I'd like to thank you all.
Thank you, Larry, for sharing that. And just before I go to Karyn, I'd love if you be open to sharing with us, right before you received your diagnosis, that's how the changes you had been making in your life prior to our diagnosis, and how that diagnosis kind of.
Well, yeah, I was supposed to start a job. I was supposed to start a job on the Monday coming, and Saturday I was diagnosed, and I was to start a job on the Monday, and that didn't happen. And So financially that hurt. And then now, I mean, even now it's almost been a year that I've been in remission, but it's still quite painful at times, and it changes my diet, and you know, I have to drink Restorlax every day because it's very constipating, the medication I'm on. And it's hard. It's hard in the morning. It takes me about an hour to come out of pain and to be able to function or even to be civil to my fiance. That's been hard. You know, it's been a strain on our relationship because I'm very irritable in the morning until I can get out of pain. So right now I don't think I can work. Really, I couldn't. I mean, it's taken its toll on my body. My body's gone through a lot of changes, and you know, obviously the treatment was difficult, but I'm glad I was treated aggressively because that's probably the reason I'm here today. I'm lucky, actually, that I was young and had some weight on me and the strength to take it, to do the full treatment, because that's what I did. Everything they said to do, I did it because I knew that would give me a better chance. I wasn't told my chances in the beginning, and I'm glad they didn't tell me. So I probably would have drank if I knew.
And and you know, when you encountered this diagnosis, I know that you had already, you know, made so much progress in your recovery leading up to that diagnosis, right? And that's what made it almost so much more.
Yeah, I was diagnosed about a week before my 1 year medallion. But
When
now
you're
I'm coming up on 3 years, so
we did it.
things are easier to manage. Sometimes, you know, I still get emotional, but life's more manageable.
Yeah.
Yeah, yeah. Yeah,
Okay.
I'm here. I'm here.
Yeah. Yeah. And Larry, a few things that you had shared with me that you might want to share today around just, you know, the hospital environment and how your previous experiences in the hospital environment
Oh, well, that's just
like
me as
offense.
an individual. Yeah, because of my mental health, I had some altercations at different hospitals in Toronto, and they weren't good ones, and it kind of traumatized me. It did really. So yeah, I guess they call it a white coat uh, syndrome, where I'm not trusting of doctors or hospitals, and I'm learning to get away from that. I'm learning that, you know, like obviously through the treatment I received at Princess Margaret, that everyone was there to help me, and that they didn't want to do me any harm. But because of situations I've been in the hospitals and my mental illness, it's like fight or flight, and sometimes a feeling I get where I feel cornered or strange feelings like that. But that's going away now because you know, in dealing with the doctors and oncologists and Yehudas, I've learned, you know, a lot. You know, they saved my life, you know, and so I'm learning to lose that aggression or you know, more trusting of doctors now, and that's and it sounds like a caveman or something, but yeah, it was pretty serious. The things that happened to me at a couple hospitals, and it shocked me. Like I at one point, it was about 4 or 5 years ago, I took a bad beating outside a bar in the Bloor West area. They almost killed me. I was using drugs and drinking at the time, and I was nearly killed in the street by a mob of men. And when I got to the hospital, I was very frightened and by ambulance. So I left. I took off, and I should have stayed and had my wounds and bones mended. But I left. And then I spent a month in this apartment by myself, got scared to death. I didn't leave. And I nearly starved to death, scared of my own shadow. And I was scared of the hospital because I'd also previously I was at the hospital. I was not doing well again in my mental illness or my addiction, and I had an altercation at the hospital with several security guards and a police officer. And the next thing I knew, I was in restraints, naked in the hallway of the hospital. And then they tranked me twice in the arm. So that was the experience I'll never forget, and that's what started my fear of hospitals. But
Mm.
that's come a long way now.
Well, that's why it's so impressive, Larry, that you were able to push through with everyone's support and build some new experiences at
Yeah.
Princess Margaret. And then the last thing that you've mentioned you might want to touch on, which I think is so important to hear, is how certain interventions, procedures kind of actually subconsciously were triggering of previous life
Yeah,
experiences.
I've had other trauma in my life as well, and like sure, there's triggers sometimes in mental illness where a phrase is said, or even in certain circumstances, well, I can say it here. I was sexually abused by my uncle when I was 5 years old, and till I was 8 years old, and he would say things that I remember to this day, and they're triggers for me. Like he would say, "Just relax." Now, when people say that now, it's a trigger for me, and it gives me like a sort of a strange feeling I don't like. And certain other things like the smell of burning incense is a trigger for me because that's what he used to do in his room while he was hurting me. So people with PTSD, as I've learned the term is, we have triggers that bring us back to that place in our mind, like it was happening at that second. We're right there in our minds when we hear those things, or different circumstances can lead us to that. I don't know how you could prevent that from happening because everybody's triggers are different, but I don't know, maybe some kind of sensitivity. I don't know how that would work in order to prevent that because my triggers are different than others. But maybe just knowing that and treating the patient with a little, little sensitivity might help, I guess. Yeah.
Thank
And,
you.
and just in them knowing that you're a person just like them. Like you have a family, you have loved ones, you have hopes, dreams. You're not just a file. You're out of life. You know.
Larry, that's so powerful, and I so appreciate your vulnerability sharing this story. I think it's so important for us because it's so relevant, and it's we're going to take these messages to hopefully help others in similar circumstances, so we so appreciate it. And Karyn, do you want to share a little bit about your experience as a caregiver through this process?
Sure. Like Larry, on April 2nd, 2022, I had just I was in a McDonald's waiting for his procedure to be over, and they called me and they said, "Oh, the doctor would like to talk to you when you come back." And I just thought, because my mother's a colon cancer survivor, so that's why I was so adamant on Larry when he turned 50 to get a colonoscopy. I said, "You're not working right now. Let's go do it." So in any case, I went back. I just thought maybe he has a polyp or something, and I walked into the office, and the doctor immediately got me, and he held my hand, and he said, "I regret to inform you that your fiance has cancer," and he said it's going to be a very long road. That's what he told me right away. So literally the floor just fell out under me, and it's like Charlie Brown going wah wah wah. That's what I heard. And the part that, in retrospect, I didn't like, I guess you could say, was that then he just brought me into the room where Larry was, and he hadn't even been awake yet. So I just found out, and then I'm holding his hand, and then the doctor's holding his hand, and then he, explains what's going on. So like all hell sort of broke loose at that moment because Larry is in recovery. And I didn't quite know what to do. It was just a very intense situation at the time. And the doctor said to me, he said he's going to need chemotherapy, radiation, and surgery because it's going to be a very long road. And that's what we were always told. So, and I was planning just with COVID and everything, I was planning on going back to work myself as a PSW. And then this happened. So that was fine. I could help Larry, and some of my training was invaluable, just with Larry's experiences with hospitals and with his mental health. And I suffer from mental health as well, complex PTSD. So we at least have that support for each other. And the really hard part, I have to say, was the beginning of everything because we didn't know what was happening. We didn't know, he just had referred his file to a surgeon. So we didn't know the surgeon's name. We didn't know who's going to call us. All we know is he has cancer. I finally get the surgeon's name, and then we're trying to book an MRI. And because of COVID, everything was, um, far in advance. Everybody needed, it was backlogged basically. So she gave me the number of like a cancellation list. And so every morning at 8 a.m., I was calling. And I got him instead of, so he was diagnosed in April. He was supposed to go for his first MRI in July. And I said, no way. So we got it to May. And so he did that. And then I guess, what I find that would have been really helpful is just having a peer support for caregivers. That's what I find like is my whole takeaway from all of this, to be quite honest, is that I did almost, have caregiver burnout because I'm living with him 24/7. And you can imagine all the emotions that go along with this because we don't know what's going to happen. I went into many dark places, cried many nights thinking I'm going to get married and I'm going to be a widow, like that's what I was thinking. Um, and we were told that he was going to have life altering surgery, like most likely an ostomy bag. And so we were sort of getting prepared for that. But through the whole journey, I mean, because I guess I'm a very organized person. I mean, our calendar was just full of appointments of all the different places we had to go to. We were at Women's College Hospital, Toronto Western, Toronto General, and of course, Princess Margaret. And it would be nice to have somebody like a peer support, a person with lived experience, even another caregiver that can help you navigate what you're about to have like happen. Like this is sort of what's going to happen, and then this is what's going to happen. Like we didn't know anything, and so you're just so stressed and having mental health. We had to keep it together, and then with Larry with his recovery, that's another layer of complexity of keeping things together because I said if you just drink, it's going to be just adding problems on top of problems. That's all it's going to do. And most likely you're not even going to continue treatment. And like it would have just been that's it.
I would have gone.
So instead we did that. But and then I made sure to find like a social worker, like to get him connected with a social worker, Emily. And then with you, Yehudis, and you had just started your role in July. So it was amazing. It was a blessing that I got in and said, Larry really needs somebody. And that has been like just life-changing in the year of what he's learned about himself, how he handles situations now, how he is in a hospital because he was terrified. He was terrified of doctors. He didn't trust anybody. And then Yehudis was really good when he had an issue or question or concern. She immediately would follow it up with that doctor, and it was done. Like the problem was solved. And the doctors, once they knew, with his mental health and knew the challenges, they were more receptive, like more. They took their time with Larry to explain things more, because there is sometimes, a lot of doctorese, and luckily I knew some of the stuff, the medical terminology, and I could go back and tell him. But again, it's just having, I think for myself as a caregiver, I would have really appreciated to have somebody that I could have talked with, that I could have, sort of shared my vent, I guess. And I didn't really have that. And I didn't necessarily want to tell Larry how I was feeling because I didn't want to make him more depressed, and then
Some time off would have been good for Karyn too.
yeah, like I had no respite.
I think you bring up a point, Karyn, because I know Larry always is speaking about how you have been his anchor throughout all of this, keeping him organized, supporting him, and yet. So we talk about the need for such a support and advocate for patients who don't have a Karyn, but then we also think about the Karyn and who's supporting the Karyn, right? So that's a really, really good point. I'm going to shift a little bit now. I so appreciate you two sharing your story, and we're going to come back to you to hear some of your suggestions. But I'm going to shift now to Gary and Dan. Dr. Bloch asked me to call him Gary, so I will. And from your perspective, the two of you, what challenges do you see for individuals who have experienced severe mental illness when they're receiving preventative or physical health care challenges? And then you might want to come into, anything that might help address those barriers or challenges in collaboration, education, resources. Either of you could jump in.
And you want to go ahead?
We're both so deferential. I mean, some of the things that I am inclined to bring up, Gary, I would like to hear your reaction to. I mean, I expect there's quite a bit of overlap. I think it's worth situating my experience as being a care provider for people with schizophrenia who are treated primarily through an assertive community treatment team. So some of what I'm about to share, I think, is related to the challenges faced by people who are, in many ways, highest needs, most persistently unwell from a psychiatric standpoint, and in receipt of the most intensive form of outpatient community mental health care available in the system. I also work in downtown Toronto in an immensely resourced healthcare setting. And I was talking this morning with some of the clinicians on my team talking about this panel, and immediately so many things came to mind, just thinking through ongoing situations that we face, on a daily basis with the ACT team, and that have been challenging for us over the years. But stigma was the first thing that came up. Experiences of people that we care for presenting to the emergency department in some distress, and that distress being immediately chalked up to mental illness. And nearly all of the people that we care for through the sort of community treatment team live in deep poverty. So there's also the dual stigma of someone presenting to a care setting with a certain label on their chart, and perhaps presenting, looking a certain way that provokes a kind of reaction among a care provider that could lead to substandard care. So stigma, I think, is a very big one. Another one has to do with trust, and this is something that that Larry spoke about, and that I've seen among the patients that I care for as well. People who have had previous negative experiences in the healthcare setting, and I think this is especially relevant for people with severe mental illness who may have had bad negative encounters with the mental health system, in particular experiences of coercion, having been restrained, having been treated against their will, or having been forced to take medications that they, one, don't agree with in the first instance, and two, that may be associated with very real side effects. And so the prospect then of being told, we're concerned about XYZ, and we think it's important for you to go see a physician, or it's really important that you go to the hospital, it's very understandable that that person would say, well, when I went to the hospital before, this horrible thing happened, and those are real experiences of trauma. And so I think the notion of trauma-informed care, person-centered care, all these hyphenated phrases, I think we should not take at face value. We should not treat tokenistically, but we should really interrogate what it means, what it would mean to treat people as humans, being mindful of the kinds of experiences they may have had either in the health system or outside the health system. Maybe one last thing, and then I'll turn it to Gary, because this relates to, I think, some of the challenges we've had connecting people with primary care. We have heard from some primary care practitioners that because some of our patients may come in unable to, owing to their illness, present their concern in a very neat and concise package, that the appointment times take very long, or because people don't show up repeatedly, that it may be more difficult for a service provider to hold an appointment slot for them. So here we start thinking at a systems level about different funding models for care providers who are working with structurally vulnerable people, shifting away from fee-for-service, where the incentive is to see lots of people really quickly. And that pressure makes it more difficult to see people who have challenges with communication, who do have many needs, and who require really a lot of time and that, that person-centered care. But that gets into the primary care setting, so I'm interested to hear Gary's perspective.
Yeah, thank you. And yeah, especially thank you, Larry and Karyn. I mean, honestly, the picture you paint with your story is worth many thousands of my words in terms of what I can offer. But so I do come at this from a slightly different angle, right? I mean, I am a family physician. I work in the community. I work in a number of communities, but mostly in sort of the downtown east part of Toronto. But in my job, I do have the privilege of kind of living through people's experiences with illness and with wellness through many different years, right? Or over many years. I mean, and I've been in practice for almost 20 years now. Have known some of my patients for that long, right? And many of my patients for well over a decade, and sort of have the ability to kind of experience the peaks, the valleys, and everything in between of their experiences with, in their lives, with health and in dealing with the healthcare system. Also in thinking about this talk, I mean, there was really a flood of thoughts that came to me, right? I mean, this issue for me, this sort of intersection between mental health issues, major mental health issues, and physical health. And, I add in also social health, right? So a full kind of spectrum understanding of health. This issue of how to navigate that intersection is really probably the biggest issue that I struggle with through my career as a family physician, right? And in trying to kind of bring together like a full spectrum understanding of what health is and what health means from the perspective of the patients and the communities that I serve. And it is really hard to bring that all together in the system that we are in right now, right? And there are other examples of health systems around the world that do this better, that understand what a holistic perspective on health is. But we still work in such a siloed space, right? Where mental health is so separated from other elements of understanding of health and well-being and social wellness, that a lot of the work that I do is about struggling through trying to get the system to understand what that spectrum looks like. So if I was going to bring out sort of a few key areas to focus on, obviously we can come back to these in the discussion later on. I mean, certainly bias and stigma jumped out at me first, right? And I know, Dan, you pointed to that. I mean, I would expand that to just, or I would sort of go deeper in that to say that I think that the biases people have about mental illness, and especially severe and persistent mental illness, exist certainly within providers, and I think they're very much built into the structures of our health teams and the structures of our health system, and we have to grapple with that in a very real way if we want to sort of bring these areas together. And I think it is, I mean, as Larry and Karyn pointed to, I think it is that bias and stigma that is probably most responsible for leading to some of the negative experiences that you've had in terms of dealing with the health system, and that many of the people that I deal with. The second thing I'll point to, which I've already alluded to, is just sort of our inability to bring an understanding of social health into our understanding of health overall. And this is something that's sort of, I found the keynote extremely useful. But I will say that one thing that kept running through my mind was that, and I deal with the metabolic complications of severe and persistent mental illness all the time, and the drugs and all of this. But I would argue that until we address the realities of poverty and housing insecurity and food insecurity and a lack of social supports that people face, it will be very, very, very difficult to actually reduce the physical health impacts of living with severe mental illness and the treatments associated with that. So those are probably the two biggest areas I'd point to. I mean, just really briefly, I just want to put on the table the realities of the silos in care that exist between mental health and other healthcare providers, and the sort of the barriers to accessing care that people face, again, due to systemic structures and how they're built. You know, even things like rigid rules around how we make appointments, around how people are expected to present themselves in very particular ways within the healthcare system, which, Larry, I think your story really points to some of the challenges with that and the way those present real barriers to getting essential care. And some of the blinders that really exist for providers in terms of being able to understand what full spectrum care is. Finally, I'll just say that I think there's a real lack of awareness in the system and amongst healthcare providers around what to do about the physical health risks that people face. I have yet to see a broadly accepted comprehensive guideline for the physical health care of people living with severe and persistent mental illness. I know there's bits and pieces out there, but until we have clear guidance on this that is really baked into care and baked into expectations for care, it'll be really hard to shift the way care is provided. So I know I'm just sort of offering up a lot of thoughts here, but wanted to put some things on the table and then we can continue this in our discussion.
Sure. Before you go ahead, Dan, I'm one of the unfortunate aspects of being the moderator is I need to keep that eye on the time. And so just to note, we have 9 minutes left. So I'm going to pass it to you, Dan, but then I think we'd like to go around and just hear, what are your thoughts for practical solutions, opportunities for next steps that we could take to help bridge the system? Yeah, go ahead, Dan.
Okay, I could wax poetic about, I get on a soapbox maybe is a better way to put it about that question, but I'll just say really briefly, riding Gary's coattails about how care is delivered. I would add where care is delivered to be a really obvious, but also sometimes out of awareness consideration. And so this, I'm speaking now from my role as a psychiatrist with the PEACH team. PEACH is this outreach-based palliative care, mobile palliative care team. And one of the docs on PEACH talks about palliative care in this context being simply good medicine delivered to people who someone else thinks has a serious illness and has lots of barriers to accessing good care. And it seems overcoming those barriers by simply showing up and showing up repeatedly and being with people where they are at can make a tremendous difference. So I think increasing the availability of outreach-based primary care services or creating greater integration of primary care and psychiatric care services for people who could benefit from outreach-based care seems like something to strongly consider.
Absolutely. And the how we do that is going to be the challenge, but certainly. Maybe I'm going to bring it back to Larry and Karyn for a few 3 or 4 minutes to hear from you. I know you had some really concrete suggestions on how things could be improved for others.
Well, I feel that aftercare should be an issue because, I mean, the hospital was wonderful, everyone was great, but after I went into remission, it's kind of like I was just out the door and what do I do now? You know what I mean? It was the feeling I had. And I mean, not to, it sounds petty, but I mean, I know there's a lot of foundations and charities out there that can help financially, but I wasn't guided towards any of them. You know what I mean? I know that it sounds bad to say, but I mean, I'm barely keeping my head above water. And I know there's people or in foundations that could help me, and I wasn't guided to any of them. We found one that gave us $100 food card. But I mean, as you know, the price of groceries in the world now, that's probably 2 bags now, groceries. And in order to recover properly, I need to eat. and
You have to buy Restoralax.
I have to buy other products that I don't normally have to buy, like Restoralax and other things, just to keep me supplements and everything, just to keep me somewhat healthy. And I mean, I've got help from some family and stuff, but I mean, I'm sure there's people out there that don't have much, that have a lot less than me, that are still suffering with the disease or recovering from it. And it's hard to do when you don't have enough to eat.
Yeah. So it's like, again, what is health and what are all the pieces that we need to actually maintain our health, right?
The body
And
needs to, sorry,
no, go ahead. Sorry.
I just, your body needs to recover and regain strength. But if you don't have fuel to do that, I don't know what you can do.
Absolutely. And then Larry, a few other notes you had mentioned to me about the consistency of providers for
Oh
you.
yeah, that was the thing that kind of I didn't like. I hate to complain, I really do, but I had several appointments with oncologists, and then almost every time I was met by a resident,
Different.
and that bothered me because I mean I'm sure everyone's well trained and educated. I'm sure, of course, but when I have an appointment with my oncologist, I'd like to see him, and at least more of the time. It seemed I only saw the oncologist once in a while. And all the rest of it, and it was a new resident each time. So they had to go overdo my file. They don't know me. They're asking me the same questions over and over. And I know it's a learning hospital. And I know that it's a very busy hospital. It was kind of disconcerting for me to only see my oncologist once in a while.
Yeah. And
And
especially,
it's an
your distress around hospitals to begin with, right?
and I had to go back and forth to different hospitals too because of they were watching my heart and other things. And that's the other thing too. Like without a lot of money, like we were at the hospital every day during radiation, and we had to eat. We had to, and a lot of waiting, so we had to have a coffee at least. I mean, it adds up. I mean, it sounds petty, but it adds up. And I don't know what the province is doing, but it's not enough.
Okay.
Sorry.
Oh, no worries. That's great, Larry. And I'm so sorry that in the interest of time, I'm going to keep moving the bus. But Karyn, did you have any thoughts? And I know you talked about the peer support workers or more coordination.
Yeah. Or just like another caregiver, or to have some sort of program where there might be some respite, or I couldn't find anything like that for a caregiver. And when, like I said, it was a year of 24 hours a day. And I mean, we had COVID in that time for 2 weeks, and then we had to be in isolation for 25 days. Like it just was so hard. Like it's the hardest thing I've ever done in my whole life. Past year was so hard. And but I would do it again gratefully. And if I can be of any help to other people, like myself, like even being a peer support, because I learned so many invaluable things just by going through it. There are holes and gaps in the system, of course. And this is like Gary was saying, and Daniel, like, there's the whole, systemic, like the whole breakdown of like you got your mental health, you've got poverty, you've got your physical problems, that your serious physical malady, and then it just adds on to it when you're just struggling financially, and it feels like there's nobody there for you. And we're in our 50s, so it's not like we have elderly parents. Like, we can't go to people and demand that they give us stuff. Like but anyway, just the peer support I think would be really invaluable, or something around for caregivers. And what Larry mentioned about aftercare. I think that is a really good idea, to develop a program for people with severe mental health, an aftercare program, because you sort of feel like you finally get in a groove, and then all of a sudden you're just out of it. There's very little contact with the hospital when you've been going every day, or at least 3 times a week, and then to have nothing. And the other thing is like a doctor has told us, every time he now goes for a CT and an MRI, we're anxious. Like you can imagine what we're like before that. And the doctor said it's always gonna be like that. It's probably you're always gonna feel a bit anxious, to see if he's in remission or if it's come back. So, but yeah, So I guess my 2 cents.
And just the last thing, I know, Larry, you said this, and I just want to emphasize it because you bring it up frequently, is that you had a Karyn and that many people don't have a Karyn. And what we need more, we can't clone Karyn, but we need some individuals to fill those roles, to be those kind of lay supports to navigate the information and everything. Yeah.
Especially like you don't know what you're up against when it first starts until you're right into it. So if somebody could tell the person what's going to happen next,
Like an orientation.
and they can expect, like, get ready for what's coming, then it would be easier for that person. I wish Karyn had that, because it all came at her all at once. So,
Thanks, Larry and Karyn. And going to check in now with Gary and Daniel in terms of what do you see as practical opportunities and suggestions for next steps?
Okay, I'll start, but I don't know, I'm really inclined to talk less about the practical and more about the systemic. Is that okay? I mean, again, I think taking in what Larry and Karyn have just shared, it makes me think about the upstream, the structural determinants of health and mental health together. One of the questions that was put to us ahead of time as a prompt to consider was, what would we change about our practice that might improve the physical health of people with SPMI? And I thought, geez, if I practiced in a society that genuinely cared about poor and working people and people with serious mental illness, I practiced in a setting where there was a robust social welfare programming, where housing was decommodified and a human right, where there were robust anti-poverty programs, affordable nutritious food, pharmacare, public coverage for psychotherapy. These things I think would improve the physical and mental health of my patients, not to mention their opportunities for flourishing. So of course, there's lots of practical, there's lots of downstream things that we might talk about that are specific to people with, say, schizophrenia who are on this or that antipsychotic medication. But I think this is what I'm inclined to end with.
Absolutely. Thanks, Dan. And we've gotten permission to go 4 more minutes. So we have a couple more minutes. Go ahead, Gary.
Sure. Well, I will use 90 seconds of that to say 4 things really quickly. So I was going to change, 4 different things. So first of all, I think patients have to be at the center of system design. Patients and specifically people with lived experience of the issues we're talking about, and especially social marginalization. I honestly think that is where the next revolution in healthcare design lies. And we're starting to do this. I mean, this is very real. I can tell you in my team, we are increasingly putting in place structures that bring those voices of lived experience closer and closer to the center of our planning, our evaluation, and our implementation of our programs. And I mean, I think as we've seen on this panel, that is really where change starts, right? Is by actually stopping and listening to experience. Second of all, I'll put in a plug for primary care here. I mean, primary care providers are experts in holistic healthcare. That is what we do. That is what we're trained in. So use us. And that's not just us family physicians. That's us, meaning all interdisciplinary primary care providers that are out there. And there are a lot of us. The third thing is, again, I mean, given that we have such experts here today from many different angles, I think it is time that we had sort of clear guidelines for the holistic healthcare of people living with severe and persistent mental illness. I think those guidelines need to be put in place. They need to be enforced. I think there need to be quality standards that reference those guidelines. I think the colleges of physicians and surgeons and nurses, et cetera, need to make sure that those guidelines are seen as true standards of care and are not forgotten about as they seem to be. And finally, just a call for focusing on social health providers as a really, really key part of the system. So these are experts in income, housing, and helping people make community connections and social connections, et cetera. And I think those types of providers need to be brought into the team as equal weight health providers along with everyone else. That was probably more than 90 seconds, sorry.
That was great, Gary. And I know this is being recorded, so we're going to need to take notes of all of these really, really integral points. I'm going to check in with Larry and Karyn, in terms of this whole discussion, what are the kind of takeaway messages that you would like healthcare providers to think about when they're trying to support you and others who may have histories of trauma and mental illness through any of their physical health needs and supporting caregivers as well?
Just that we're human, and that, like I said before, the disease doesn't discriminate. You have money, if you have no money, different different ethnic groups. It's the rapacious creditor, and it's very scary. But I'm one of the lucky ones, and I'd like to give back someday if I could.
I think you are giving back right here, Larry.
Yeah, I think exactly what Larry's saying, and that just for primary care physicians to really get to know, if they can, get to know the patient. Like that was so integral for Larry's recovery was that with Yehudis, like she was meeting him sometimes twice a week, at least once a week, and just working through his trauma and working through things, because as things went on, when he went through chemo, there would be issues and problems. And then in radiation, and there might be some other things where an example was like they would say, now just relax, or when he was having a scope done. So there was words and things that were used that would trigger him, and he would, it was scary. It was a scary place. But yeah, it's just getting to know the person, I think, is a starting point. And I think definitely having gaining valuable information from people with lived experience that's if you want to know the problems, talk to the people that have just gone through it. I mean, yeah, there was many things, but we had a positive outcome. We were the lucky ones, because it didn't look good going in. And Larry didn't even have to have surgery, which we were told all along. And the radiation eradicated the tumor. So, the surgeon was literally jumping up and down, taking a picture with his cell phone, going, "It's gone, it's gone." Because, because
he showed me two scars. He showed me.
We were always told it was surgery, and life-changing surgery or life-altering, so, but yeah, that's what I'd like. And just something along the lines of, like, I'm a very resourceful person, and so I had to look through things, but there's not a lot out there. Like, it's not easy accessible for most people. It's just, that's the problem. It's not easily accessible.
I couldn't imagine someone more impoverished than me, like someone maybe, is homeless or something, or not homeless, but like on OW, which is a very limited amount of money. I can't imagine how they would survive cancer. Or someone alone,
Just alone.
a single person.
Yeah.
I couldn't do it alone. No, I couldn't. I couldn't have done it without care.
Larry, Karyn, Gary, Dan, I can't thank you enough. And I think that take-home message that, the patients we meet are humans. They're like, they're just like our family and our loved ones, and they're human beings just like us. And how can we just get to know them better? And I think this conversation can continue on for a couple more hours. So I'm so apologizing to cut it short. I hope that we can continue this conversation after the conference, and I'm just so incredibly grateful to be a part of this.